Hi everyone, Dr. Michael Miyazaki here again with you with another episode from our Vista Apex Solutions YouTube series. And today I'm really excited about the subject we're going to talk about. It's the indicator. But as our interview guest, we have Dr. Ryan Walsh, who is a practicing endodontist down in Texas. And not only does Ryan or Dr. Walsh practice endodontics, but he's involved in teaching. He's helped Vista Apex with our R&D, and so we really value his opinions as a true clinician. So, Dr. Walsh, thanks for joining us today.
Yeah, Dr. Mike, good to see you again. Thanks so much for having me on.
I really always enjoy our interviews, and so we're gonna. If you've been watching kind of the content that Vista Apex has been putting out, we are just recently have just launched the indicator. And so, Dr. Walsh, I think one of the first questions that I'd like to get your perspective on is now that now that it's out as a practicing endodontist, um, can you explain in brief terms what the indicator is?
Sure. Yeah, I mean, just the down and dirty version is it's a chairside tool that allows us to measure how clean our canals really are. I mean, that's a very distilled version of it. Um, to elaborate more, I mean, it's a chairside assay that we use to detect debris inside the canal. It detects ATP, so any living type of cell that's internal, whether it's bacteria, pulp tissue, blood. It'll detect the presence of that, and then it'll give us a score on the machine telling us, how much debris is there, on a scale of 1 to 100, 100 being the most debris, one being darn near sterile. It gives us a good objective measure, if you will, of how much debris is still in that canal, and whether we need to irrigate more, clean more, or whether we're at the right spot.
And no, it's great. Yeah, this is kind of a game changer. So the first time you used the indicator, were there any surprises about the information it shared with you?
Um, yeah, again, kind of much to my surprise, having been in private practice for well over a decade, you kind of get used to your clinical protocol, and you see things that work, you see things that don't work. But one of the things that really surprised me, and again, I'm still laughing about this, that it was surprise finding, was that it's really good at detecting blood or tissue fluid, not just bacteria. I think as clinicians and endodontists, for sure, sometimes we get very, narrow focused, or get blinders on, and really only focus on how clean is it with bacteria, in necrotic cases, which of course that's so important. I mean, we've focused a specialty around this, but what about the vital cases? What about the cases with little lateral canals or little grooves and fins? And to me, that's where I found the most surprise, was that I got a vital case that read about 35 or 40, somewhere in between there. It was a number that I was expecting to be really low, single digits, because it was, straightforward pulpitis case. You clean shape, you use your ultrasonic activation, and I'm just expecting to find a low number when I did my indicator reading. And sure enough, it popped back at, a fair amount, telling or a number telling me there's still a fair amount of debris left. So I went back and re-irrigated and got the number low, but nonetheless, it was a surprise finding on a case that I thought would be routine, slam dunk, in and out.
Yeah, so let me ask you about that. So, just to kind of give the viewers or listeners an idea, if we have a score of around 30 or below, then we can be fairly confident that we've gotten the canals cleaned out to a fair amount. The lower the number, obviously, the better.
Right.
If we're above that, like 50 or above, then we know we have some more work that we should do before we do the obturation sealed up.
Totally.
So, yeah, in this case, uh, if you had sealed that up, do you have any idea of what you might expect? Maybe not in this case, but just in cases in general, because we don't know
Yeah.
how clean we get those canals.
Well, that's a great question, and hopefully something that, as time goes on, we're able to put the indicator to a clinical success standpoint. But to me, it tells me there was still some fluid leakage in there. Again, whether it was from a lateral canal, whether it was just extra pulp space in the isthmus or a fin, who knows? But to me, the fact that I was getting a reading back above the acceptable threshold to seal it on a vital case that's supposed to be the highest prognosis in endodontics, to me, that was kind of a, I don't want to say a game changer, but an eye opener. I think that's a good way to put it. That sometimes those slam dunk cases aren't as slam dunk because there's other things going on. And
Yeah.
biologically, we know that to be true. So to me, that was a pretty cool moment of, yeah, the proof's in the pudding. All right, Ryan, go back to the drawing board. Time to irrigate again on a, what would, again, should be a routine case.
Yeah. Last week I was doing a simple root canal. Simple. It's just a single canal. It's on a central. And, I cleaned it out. And as I was getting ready to obturate it, I did not have an indicator. And I was thinking, boy, it would be nice to have an indicator, even though it's a simple case, a single canal, we irrigated it, we used activation and everything looked good. It still would be nice. Once you get used to having that information, you miss it when you don't have it there anymore. So before you seal it
Totally.
up and kind of commit to it, you'd like to think, okay, I got everything out of there. So no, I can understand that. So with how you've used it, what do you see the potential for the indicator just in everyday endodontics?
I mean, it's so easy to use. That's part of the beauty of this is that it's simple, it's easy and straightforward. There's no new workflow that you have to do. It's not like you're adding an adjunctive irrigant or you're getting the newest, latest, greatest innovation that's going to clean your canals. I mean, this is so simple and straightforward that, I take a few cc's of water right before I dry, flush that through my canals, drip it onto the applicator and plug it in the Endocator. And then I start to dry my canals. And if I have to go back and irrigate, okay, I have to go back. But many times it tells me I'm below the threshold and I'm ready to obturate. But just having peace of mind. I mean, again, those of us that have done thousands of root canals have also seen there's some that come back that fail. That you always scratch your head and wonder, is this something I could have prevented, or did I get it clean enough? Nothing's more frustrating to me than a vital case that was by the textbook should be a one-step endo, and you do your root canal, it looks beautiful on the X-ray, and a year later or 2 years later, it comes back with a lesion. It's like, well, where did I go wrong? What was I doing that's not allowing it biologically to heal? And so I think having some peace of mind and some predictability with our treatment, I mean, again, to me, it's a no-brainer.
I think you're absolutely right. And you just brought up some good points that the workflow, the use of the indicator just kind of fits into your typical workflow, I guess. It doesn't really disturb things too much.
No, I mean, truly, it takes 10 seconds to get the reading. It probably takes 20 seconds to actually put a little bit of distilled water from a 3 cc syringe into the canals, put it on the applicator. I mean, we're talking something that start to finish is less than a minute. I already have distilled water in a syringe sitting next to my, in my 12 o'clock anyway. That's just our standard setup. So to me, to have that there, it doesn't add any more time. I don't have to change anything. The indicator sits on my 12 o'clock. And I mean, it takes up such little real estate that it's kind of a non-event. You know?
Yeah. And I guess when you look at it, just like time savings, because for anyone who's done a root canal, that if, like you mentioned, if we find out 6 months or 12 months down the road that it really hasn't healed and maybe that lesion's getting worse, then we have to go in there and retreat. And then that's going to cost more money. The patient's not going to like it. And if we had just spent 30 to 60 seconds more on the front end, just to be sure we had the canals cleaned out before we sealed it up, that would have made life much easier, I would
Yeah,
suppose. Yeah.
yeah, totally. And at least let's say it does fail, right? Not every root canal is successful, no matter how clean it is. At least at that point, you know that, hey, I've done everything I can inside that canal. And so the chance of me going back and retreating it, if I had a good number, the chance of me going back and retreating is probably a little bit lower, unless there was, some coronal leakage or deep caries again. But then I'd be a little bit more inclined to go right to an apico and say, hey, I've done everything internally that I can, orthograde. So now let's go retrograde. It kind of takes a little bit of the guesswork out, of where the next step should be.
Yeah. So, you've made it sound easy, but some that are listening or watching may be wondering, like, is there a learning curve? You just said you put some water in there, you pull the water out, you just test it. Is there much of a learning curve, or is there any
I,
challenges that you see?
I struggle to say learning curve because I mean, we're bonding composites, and that's like the most technique sensitive thing that we could possibly do in dentistry. I mean, Dr. Mike, you've been teaching bonded restorations for how many
Yeah.
years? That's a technique sensitive learning curve challenge right there. I mean, to use the indicator, no, there to me, there's no learning curve.
Um,
Uh, if you can aspirate distilled water out of a canal with a 3 cc syringe and put it onto a Q-tip, you have completely mastered the indicator.
that I mean, I know it is that easy, and it might be. If you haven't, we've done some other videos where we actually showed Dr. Gilbert, Dr. Cross, even yourself. We've talked about the actual technique of using the indicator, and you're absolutely right. It's not much harder than that. We just at the very end irrigate with a little bit of sterile water so it's not contaminated. Withdraw some of that and just test it in the little reagent tube in
Yeah.
the indicator, and it's that easy. So yeah, it doesn't add
Yeah. I
much
mean,
more.
it's like I don't want to sugarcoat it, but I certainly don't want to over dramatize it. It's truly just that easy. And I mean, it's just as easy as picking up a different syringe. That's it.
So let me ask you this. Now that we talk about how easy it is, I'm sure at first because it's a little box and it's almost like a little magic box. It seems a little novel. It was new to use it at first. What convinced you that this was something to be taken seriously?
You, that's such a that's such a wonderful question. Well, we know this technology isn't new per se. It's just new in this particular application, which to me is part of the beauty of this is that it's taking something that's been around in clinical lab sciences for a long time, ATP assays, and it's something we all know. I mean, all of us dentists having somewhat of a science background, we know what ATP is. We know what it's telling us that there's some vital cells there. So to me it makes so much logical sense that if we can measure what biological activity is going on inside, I mean, uh, to me it makes sense. It's not a whole lot of I'm not taking a whole lot of leap of faith knowing that it's measuring what's there again because this technology has been used elsewhere for so long. This is just a really novel application of existing technology.
This is a little bit different question, more because we've been talking to you as the endodontist, but now if we talk to you as the educator,
Mm.
how do you think this will change the lives of like the endodontic residents or even the dental students that are learning to do root canals? Because in the past, doing a root canal is probably one of the most difficult things that we had to learn to do while we were in school. And, you know, could the indicator be kind of a game changer for the dental students going through learning how to do endodontic procedures?
I mean, in my opinion, unequivocally, yes, absolutely. If nothing else, then just to tell that dental student that, hey, you've cleaned enough. Because we preach all the time that you truly can't irrigate the canal enough. I mean, there's no such thing as over irrigation of a root canal system. So I think teaching some of these young people at the critical steps in their education that this is what it takes to get a clean canal, I think that's of utmost importance. But taking that a step further, not just your first root canal or your second, but when you're doing these not only in dental school, but then into residency, proving to yourself that what you're doing is sustainably predictable, I think is incredibly important. So I think from multiple aspects in the dental curriculum, the learning curriculum, that I think this should be an integral part of root canals from day one all the way through residency. And then again, for those of us who are out in private practice, I mean, that's just proving that what we're doing is continually successful. And again, we're working on the human body. So it's not always just as simple as moving from A to B to C. I mean, if root canals were really that simple, I'd be out of a job. And so I think proving these biologically sound principles over and over is something that's going to be really advantageous for our specialty.
You know, I agree with you on that. And I'm just trying to think, today when we do a root canal, how do we know how clean it is? I mean, it seems to me like it's a little subjective. We have to hope that our technique was sufficient. We have to hope that we found all the canals, and we have to hope, that there's a lot of things that have gone right. The indicator is kind of an objective measure of how right we were. So
Totally.
maybe I'm missing it, but how do we tell how clean canals are today? Is there without the indicator?
Yeah, I mean, I think Dr. Gilbert said it most eloquently. You can't see clean. And that's
Mhm.
just so true. We're disinfecting with 20 milliliters of sodium hypochlorite with so many minutes of adjunctive irrigation, whether it's ultrasonic or whether it's laser. We're doing all of these because studies and peer-reviewed journals have told us that this produces a clean canal space. You know, which that's the best we have, right? I mean, other than the chairside assay that is the Endocator now, but previously we're just basing it on studies that say in this subset of patients or in these extracted teeth, this worked well. We don't have anything to say that on my patient right now, Mrs. Jones sitting in the chair, your tooth is clean. We're basing all of our protocols upon assumptions of studies or people who have done thousands and thousands of cases telling us this is how to do it. But we don't really have any way to say that right now, today, in my chair, this canal is clean enough.
Yeah, no, that's absolutely right. And then I know you've been involved with a lot of R&D, excuse me, where you're using like this bioluminescence with the indicator, using some biofluorescence. In endodontics, what do you see the future? Do you see the future where more of this technology is being used? Is this a way that is this kind of opening a door in endodontics to be more successful, or how do you see the future? Kind of took your clinician hat off, took your educator hat off, and now we're kind of in the R&D section.
Yeah.
What do you see as the future of applying this type of science?
I mean, I think anything that makes us more predictable and more successful is going to be a winner long term. You know, uh, it's hard to look out into the future and hang your hat on one technology and say, "Hey, this is going to be the panacea that fixes everything." No, I don't think that's true with really any one particular set of tech or one particular piece of technology because it's the collective whole. It's taking these different pieces and these different facets and saying, okay, yes, I understand that shaping my root canal removes X% of bacteria and it should be this percent successful. But we've seen over the last 50 years that root canals have become more successful. It's because of technologies along the way that are being invented and then incorporated with other groups of technologies and uses that continuously advance our specialty and make what we're doing more predictable. So if I can use the indicator to say, okay, my reading's not as low as I thought it was, is it ready to seal? Or then I'm taking the other bioluminescence camera and looking in and saying, oh, there's a fracture there. Oh, that's why I'm getting this higher number, or it's not as clean as I thought. Now you're taking technologies and pulling them together to get real live feedback of why aren't my protocols working? Why is my root canal not successful, or why is it not as clean as I thought? So I think taking technologies and grouping them together and really kind of proving to ourselves the why and the how. That's really how we're advancing dentistry.
I think this is going to be really exciting because, the endodontist, you have your microscopes and it's still, as you were saying, you can't see clean. So this is just another test to just measure the viability of how well we did, what we thought we did. And I think this is going to be a game changer, and it's going to be interesting to see how the future pans out with technology like this. So no,
Oh, right.
it's going to be really exciting to see how this goes. Again, this is the kind of the initial launch of the indicator. I think that the doctors that get on board early, I think we're going to see some great results, hopefully in the near future. Yeah, I think one of the hard things about this is we think the indicator would be maybe something that endodontists would use, but then for the general dentist, since most root canals, the majority of root canals are still done by the general dentist. And general dentists, we're trying to do so many different things for the day. Like you mentioned, we're bonding, we're doing crowns, we're doing restorative. Then we squeeze in an endo, unlike an endodontist that's really focused on endodontic procedures all day long. And it just seems like for the GPs, this would be a great tool just to be sure that we haven't missed anything. Dr. Walsh, maybe one last question is, if we're in there and we've gone through with our best of our endodont technique, we've done our filing, we've done our irrigation, and the indicator still gives us a higher number than we want. Again, we mentioned it, we on a scale of 0 being totally clean to 100 being as dirty as it gets. And we would like to ideally have that canal cleaned out to 30 or below before we do our obturation, seal that area up. But what if we've done everything that we thought we could do? We've followed our protocols and we still have a reading of like 60 or 70. What are some of the things that the clinicians, how do we interpret that, I guess, is a better way to ask.
So I think at this point in time, my immediate default would be to put calcium hydroxide inside the tooth and see that patient back in a few weeks. I mean, we've done study after study after study with one visit, two visits, calcium, no calcium. And it's really hard to go against using calcium hydroxide as an intracanal medicament. So if you're not getting the numbers you want, whether it's a vital or necrotic case, place calcium hydroxide. Let it sit in there for a couple weeks and then see that patient back, re-irrigate and flush the calcium hydroxide out, and then give it another test. If you're still reading 70 on the second visit, then I think I'd really be scratching my head of extra canals or a crack or a fracture, something along those lines. You can always get a CT scan as well. I do this frequently if I'm inside of a tooth and I think there's an extra canal but can't find one. I'll put calcium hydroxide in the tooth, take a CT scan, and check for extra canals. And I think again, combining technologies provides us a really well-rounded set of data. So I think
Yeah, no,
I have a hard time not placing calcium hydroxide. Maybe I'm a little old school, but yeah, that's my go-to.
no, I think you're absolutely right. So if we have if we've gotten the bacteria out, but we have blood in there, we can still get a high reading,
Oh
as you
yeah,
mentioned.
yep,
So if we have a fracture in the root, we could still get a high reading because there's still bacteria either in the crack or maybe there's blood that's getting through that crack.
sure.
And then if we've missed the canal, then yeah, we could begin a high reading also. So if you've done everything you thought you should do and it still comes out high, then the endocator is kind of indicating to you that there's some other things that could be going on. So yeah, I know
Totally
it's
right.
like a tongue twister after a while. A
Yeah,
while,
totally.
whatever the indicator indicates is what you should follow up with. But no, that's great.
I'd pitch it or throw it to general dentists this way: that if you had a machine or a piece of technology that could tell you if your composite was suitably bonded or had great adhesion at the time of placement, or if when you placed a crown, you knew there was no marginal leakage or air bubbles anywhere, and you truly had the best seal that you could have, you'd use that technology. And so I think this is a kind of an akin or a parallel to that in endodontics, saying that we have live testing right now telling us we're doing the best job that we can.
Yeah, no, I think that's a great way to put it. Something that we could all relate to is there's a lot of things in dentistry we think we have to kind of take it for granted that we do the best with the materials we have and the best with the procedures that we're going through to accomplish the job. But there's things that, as you mentioned, when you do a composite, you never know if it's cured all the way through or at the interface where the tubules are, if we sealed everything up, but we kind of just kind of hope that things are going well. And this is just something in endo where we don't have to hope anymore. We have something objective. We have a saying in occlusion that if you can't measure it, then it's just opinion. But if you can measure it, then it is fact. So it's kind of nice to be able to have something that gives us that objectivity as we're doing our root canals. Very
I like that.
good.
I'm going to steal that quote if you don't mind.
Yeah, that's well. I wish it were mine, but it's a quote that I've used too. So yeah, you can take it. It's
Thank you.
actually there's an occlusion philosophy, and that was quoted from Bob Jenkelson. So or Bernard Jenkelson. Bob
Okay,
Jenkelson was his son, so we use that often in occlusion.
got it.
No, yeah, that's very cool. No, I want to thank you for your time. I want to thank you for your insights. And for everybody watching this, if you like the information, hit the like button. If you want to make sure that you don't miss one of these episodes, because we do one every week, hit subscribe. We'd love to see our subscriber count go up. But we're really trying to create with great clinicians like Dr. Walsh, just a community of like-minded individuals and clinicians who are trying to do the best for the patients. And I think this indicator indicates that you are trying to do the best. Now as Dr. Gilbert said, you can't see clean, but once we obturate that canal, we're kind of hoping that we got all those canals clean and we found all the canals. And the indicator is just another tool we can use to objectively measure that we did accomplish the job we set out to do. So thank you for joining us. And Dr. Walsh, thank you very much for all the information.
Of course, Dr. Mike, great to see you again. And thanks for having me on. I appreciate it.
Oh, thank you. We'll see you again soon.
Take care.
Yeah.